This video is going to cover just some of the basic concepts in disease transmission and disease progression at an individual and population level, just with an epidemiological lens rather than like a pathology lens. So just a basic differentiation in how disease can be passed from one person to another is horizontal or vertical. So with horizontal, it can be direct, like person to person or environment to person, and I'll come up with some examples in a second. Or indirect, where there's like an intermediate step, like you didn't get it directly from someone sneezing, but maybe they touched an object and then you got it from the object, or a vector like a mosquito. And vertical is mother to child, and that's either in utero or in milk, and I think just really anything that happens really early, like in the first couple hours after birth, maybe. I think also possibly genetic can be looped into with that, but don't quote me on that. So there's also a variety of routes. So eating stuff, breathing it in, direct contact, like touching something with your hands and then your mouth. Iatrogenic, I don't totally know how to pronounce it, but that's when I think you get it from the hospital. So while you're in the hospital, you get it from someone who's sick there, or maybe an infection from a wound that wasn't sewn up very well. You got it in the hospital. Sexual and vectors. So just some things that can be person to person are like from a sneeze, or from a hand to mouth, or from someone in the hospital, or from like an STD. Ingesting something is like from environment to person. Person, object, person, like sneezing on an object or touching an object, or someone in the hospital in the room before you if they didn't clean the bed very well. And vector to person is kind of self-explanatory. So now just differentiating some terminology. So we use the terms infected and disease kind of synonymously in English, but they are different ideas. So when you're infected, the agent's multiplying and your immune system is responding. When you're diseased, you have an infection that's causing clinical signs. So you can be infected and not diseased. So you can have an infection, but you have no clinical signs. Although you have the illness, you don't have any overt signs. You don't know you have it. You don't have any symptoms. But if you're diseased, you're infected, provided that it's an infectious disease. Colonized means that agents are multiplying, like the disease is multiplying, and your immune system is not responding. So that could mean that it's like not a very virulent strain, or you're very immunosuppressed or something like that. And latent is when the agent is present but it's not multiplying, it's just kind of living in you. There's a part of some viruses' life cycle is like that, where they just kind of integrate their genetics into yours. Like herpes, where like you can have herpes for life, but are not always it's not always multiplying in you. It can just integrate itself into your DNA, and then spontaneously go from being latent to lytic again. Basically, it can start multiplying again at random almost, or in response to some stressor. A specific term that is more ambiguous is carrier. That's someone who harbors the organism, but they don't show clinical signs, they don't have an immune response, and they're contagious. So they feel no reason to go to the doctor, and even if they did, the doctor might not be able to find the disease, but they're still getting other people sick. So in the context of this group, let's see what it is most similar to. So they're not infected because they're not mounting an immune response. They're not diseased because they don't have clinical signs. They might be latent. Latent's close. But with latent, you're typically not contagious when something's in the latent stage. Colonized is what it's most similar to, because when you're colonized, the agent's multiplying and you're not responding. I guess the main difference here is that a carrier, it's basically just how you would use it in the English language. Someone is a carrier. I guess they can also be colonized, but they're not a colonized. They're a carrier. I guess it's mostly just. I guess someone who knows more than me would be able to spot the differences, but they're pretty similar. One of the more tragic examples that everyone talks about is Typhoid Mary. She's kind of villainized in the sense that she was like a maid or an au pair or something like that that was a carrier for um, I forget the name of the disease, but typhus, typhoid, some disease. And I think a lot of people got sick and a lot of people died because at the various homes she went to, she got people sick and she was a carrier and didn't know she had it, so it's not really her fault. Um, but yeah, that's an example of how carriers can be a pretty big deal. So when a disease is clinical, it means there's visible signs. Preclinical means that the disease is at a really early stage where there's not clinical signs yet, but clinical signs are soon to come. A subtly different thing is subclinical. Subclinical is when the disease is present and doesn't have symptoms, but it's not going to go on to become clinical. And the difference between these two is that with preclinical, the reason you don't have symptoms is because you're at an early stage of the disease. Well, with subclinical, it doesn't matter what stage you're at, it's more just that it's not severe enough to create clinical signs, even though you have the disease. And chronic is when it persists over time, and it's usually not severe. It's usually just a low chronic infection for a very long period of time. So as far as mapping the stages of disease in an infectious setting, we have being exposed to a sufficient cause, so someone coughing on you enough. Then you have the pathology being detectable after this organism, like someone coughed on you, and now you have some sufficient amount that your immune system can't fight it, so they're multiplying out of control. And the time between that happening and when the pathology is detectable, so like when someone coughs on you and a few viruses end up in your blood, although you're technically infected, they're not going to find the disease yet. You haven't gone through the stages of like, because how we detect disease is usually not like for blood tests. It's not typically even finding the virus. Well, it can be, I think, but it's often detecting your response to the virus, so your antibodies and stuff. So this latent period is the time between when you've been coughed on and you have some viruses in you to when there's enough that we can detect it in your blood. And then between that and when you have overt symptoms, that's the incubation period between when you've been coughed on and when you show symptoms. And then you have the final stage, whether you recover or die from it. So there's different types of prevention, and they focus on different parts of this cascade. So primary prevention is either reducing your exposure or reducing your susceptibility. So reducing susceptibility is like vaccine. Reducing exposure is like wearing protective equipment. Secondary prevention is early diagnosis. So before you're clinical, when you're subclinical, or being able to detect, or preclinical, I think would be more accurate, when you're detecting it early. And between when you start to have symptoms and when you recover or die, there's therapy. So it's essentially preventing death. For non-infectious diseases, this cascade is kind of different because we're not as concerned about this exposure window we're not as concerned about this exposure window with infectious disease, but with chronic disease, exposure is something that takes a lot more time to accumulate, like accumulating enough cigarette smoking to cause lung cancer. I think I'm going to use cigarettes because that's a good one for illustrating this. So you have your first contact with the exposure, your first cigarette, and then there's some cigarette number, like let's just say like 1,000, where all of a sudden it's possible that you can get lung cancer from it. But after that 100th cigarette, you're probably not immediately going to have lung cancer. There's probably still some time where you have accumulated a sufficient dose, but you might not have the disease yet, and then there's disease diagnosis. So this time between your first cigarette and when you've had enough of them that you're all of a sudden eligible to have okay, so I'll explain it like this. So you have the etiological window, that's the time spent accumulating enough exposure, and once you've smoked enough cigarettes, some cascade is triggered where all of a sudden you have enough DNA damage in the tissue of the throat and lungs that it's possible for you to get lung cancer, but there's still a cascade that has to occur that leads to actual cancer. Like maybe, I don't know enough about cancer, or maybe you have like proto-oncogens that have been activated here, and now you don't have cancer yet, but you now, the process has been set in motion. And the time between that and when the disease occurs is called the induction period. So even though you've accumulated enough exposure, you still this you've been exposed enough to be diseased, but you're not going to be diseased right away. Some time goes by before disease occurs. Then the latent period is the time between when the disease began, so when that first tumor cell exists, between when it's big enough to be diagnosed, basically. So when you're doing like a cohort study and you're trying to measure whether someone's exposed, this is the window that is relevant. Because let's just say once you've accumulated enough exposure, any additional one is not increasing your risk any further. That's been set in motion once you get here. This is more for continuous exposure, that this entire window is relevant. But if it's categorical, where you're only exposed if you reach this threshold, and anything less is essentially equivalent to not being exposed, then this entire window isn't relevant. But this time when you've reached that full exposure is where you should be trying to measure exposure status. And messing up this is basically the biggest source of error in misclassification of someone's exposure status, is picking an irrelevant time window, or if it's categorical, measuring it too early, and they go on to be exposure positive but they weren't yet, stuff like that. Disease status is irrelevant here, because even though someone's sufficiently exposed, if you measure them the next day, they haven't had enough time to develop the disease. The cascades they're in the process of becoming diseased, but you might measure disease status incorrectly if you choose the wrong time in this induction period. And so they've had their first cigarette, they've smoked enough to set this like oncogenic thing in process, and now they have this cancer cell, and now they are technically at risk now to be detected. So they're accumulating time at risk now, basically, because up before then they weren't technically at risk, because it would have been impossible for this exposure to cause the disease. There's some waiting lag time. So now they're officially at risk. So as far as disease in populations, how we describe it, sporadic is just when there's random bursts that have no real pattern. Rabies can represent an epidemic, but rabies is often sporadically distributed without rhyme or reason. An endemic, you don't say there is an endemic happening, you say a disease is endemic to a region or something like that. It's the usual regular occurrence of the disease in a population. So in Canada, the common cold is seasonally endemic, where the number of cases go up and down at regular intervals in the winter. It's not an epidemic, it's what's expected. An epidemic is when disease is occurring in excess of the usual amount, or in a place it doesn't usually occur. So in late 2019, COVID began. It probably began a bit earlier than that, but the epidemic in China just kind of skyrocketed. And a pandemic is an epidemic that crosses international borders. So it's basically throughout 2019, little epidemics happened with COVID in all of these different countries that amount to a pandemic, because it's an epidemic that's crossing international borders.